There is another question. Do you think finding the cause is useful?
I do think finding the cause is useful, yeah, because it allows two things to be to proceed. Two major things. One, if you identify the cause, then you can start developing solutions to reverse it, and you can also develop solutions to prevent it now. And so preventative efforts can't be directed to secondary sources because they're going to be ineffective. And even today's whole talk on obstructive sleep apnea, it's actually a drop in a bucket of actually a much bigger thing, because the question is how do you get all these folks, especially kids, developing sleep apnea, and then it kind of maturing into a much more moderate and severe case as they kind of get older if it kind of goes unaddressed. And because it's not just about having like a tongue occluding your airway or a nasal passage not working very well. The more severe the sleep apnea, the more occlusions there are. It's not one occlusion becoming dramatically worse. So more structures begin to fail in the airway is what you're looking at. And just like our body, as we age, muscle tone weakens and things reshape and we put on fat, all of that also happens with the airway too as it gets remodeled and shaped. So to kick things off, today's talk was about assessment management of sleep apnea, obstructive sleep apnea, and it's just a picture of, included the tick again, as kind of Lyme disease being considered the great imitator at one point in time, and then extensive prevention. And this is kind of a good point to the person who asked about knowing the cause of things. It's our efforts to now be mindful when we go for a hike and to check our skin or maybe dress appropriately or inspect our hair, or if someone presents with certain symptoms, to go ahead and order testing that could possibly take into account. And that's allowed for not only for us to prevent cases, but also for us to monitor tick populations, and then also for us to respond faster with treatments, so as to intervene at a stage, hopefully, that is more likely to reverse the symptoms and the condition for the patient rather than having to just focus merely on compensating. And so I have no disclosures to make. So where I left off, basically last time I mentioned was sleep apnea commonly presents as psychiatric symptoms, and which is a reversible cause. And to look beyond, the stereotypical older male, but to consider non-obese individuals, females, young individuals, and patients with neurodevelopmental disorders are all cohorts at risk of sleep apnea. And so a variety of mental health symptoms that we typically classify are all indications for retrieving a sleep study. And oftentimes providers don't know that because when they go ahead to fill out the referral, there's no box to check for it. So they think that that's not actually an indication. And that actually drives a lot of major decision making there. And to be mindful to refer early because the process can take several months, maybe up to a year if you're looking at from time of referral all the way to time of definitive treatment. And so the long story short I was trying to get at is the psychiatric symptoms in many cases in all cases are brain symptoms, and they're reflective of breathing problems in many cases. So my objectives today are to look for the signs and symptoms, not beyond gender and BMI, to screen for sleep apnea. And then understand that sleep studies should be a regular part of a mental health workup. In the same way, it's common to check a CBC for anemia or a thyroid test, which I would argue probably have a lower sensitivity for detecting the cause of the patient's presenting symptoms. And then management requires regular follow-up and a multidisciplinary approach. So treating this really as a team sport. So defining obstructive sleep apnea, the most important thing to understand is that when you're talking about this, you're trying to understand, oftentimes folks will say, when it's an older individual, yeah, well, the reason is if they're elderly, the tissues are sagging and maybe they have a lot of adiposity and they have a thick neck. So that's actually impinging on the airway of the pharyngeal muscles. But with all these other cohorts I mentioned, individuals who are slim, children, and so on, that's not necessarily the case. And so you want to think of it actually as a face and a head that doesn't breathe well. And being someone who may be obese or being someone who's older, and so the tone of the airway is now starting to sag, those are things that fit within the category of a face that doesn't breathe well. And so just a quick primer. OSA refers to the obstruction of the upper airway during sleep, causing an arousal. And this is most often than not without awareness to the actual person. And this repetitive cycle of sleep fragmentation interrupts the brain and the body's recovery processes that take place while sleeping. So when thinking about the airway, you want to understand that there's numerous structures involved. There's the nasal cavity, the nasal pharynx, the oropharynx, and it kind of goes as far back as the hypopharynx, but also there's the oral cavity itself, which is more important for actually guiding airway development. I'm not going to go into a lot of detail about that today because it's a massive topic, but just to kind of expose you to it, so that way when you're thinking of why is all this occurring, why is it so prevalent in young people, how come they're finding so many cases, you actually have to look towards there in order to find the answer. But in terms of possible causes of obstructions, showed this last time, but just some quick reminders, some common reasons, because maybe you have an enlarged turbinate, or you have enlarged adenoids or tonsils. That's a common one. And then as well, for the individual, they may have a tongue that kind of recedes and falls back onto their airway, maybe because their jaw is particularly small. And so they have a receded jaw, so which is basically the bed of the tongue. And so as a result, it falls back. And in terms of understanding the treatment, the reason these treatments have such a significant impact is at least at a mathematical or a physical relationship, we want to understand that airflow responds, in an exponential manner or a quadratic manner. So every millimeter that you open up to that airway, whether that's jaw moving forward because it's properly being aligned, or you have a CPAP that's operating as a pneumatic splint to open up that airway, or you have tonsils that have been removed, every millimeter you claim actually has an exponential effect on the individual for getting more airflow into their body. And, this is an important point that often gets overlooked when we're thinking about sleep apnea, because we're just thinking that the airway's blocked, but it's not just about breathing, it's about breathing through the nose. And so the nose is defined for breathing, the mouth is defined for chewing, and it's specifically optimized for those functions. So we're often familiar that the nasal passage is responsible for maybe warming and humidifying the air, and then the nasal hairs and the ciliary mucosa are responsible for filtering the air as well. What's also important to be aware of is that the paranasal sinuses actually secrete nitric oxide, and that only diffuses into the nasal passage. Very little diffuses into the oral cavity. And that's important because it actually, I don't know if it necessarily sterilizes, but it's antimicrobial. And so it does, and it's actually antiviral. And so air that moves through the nasal passage is actually treated in many different ways. And that nitric oxide that's inhaled through the nose actually carries down into the airway of the respiratory tract and into the pulmonary vasculature. And as a result, that causes dilation of the respiratory tract and dilation of the pulmonary vasculature. And so oftentimes, if you look at cases of pediatric asthma, or at least the cases I see in my office where a kid has a comorbid asthma condition, you often see their mouth breathers. And so there's a quite expanding literature base on the limitations of nasal breathing, not carrying that nitric oxide to actually open up the respiratory tract. So the mouth actually doesn't provide any of those above benefits. And so its responsibility is to keep the tongue pushing against the hard palate, not sitting in the jaw. Actually, it's supposed to be sitting, touching the surface or the roof of your mouth. And the effects of that is actually to grow the face forward and outward, thus enlarging the airway. And so there are individuals who actually will retrain they're kind of, you can think of them as oral facial PT, to actually retrain individuals, and children who do it can actually reorganize their airway, but it also benefits adults. So with the assessment, don't think, can I find sleep apnea? Think, is there a breathing problem? That's what you want to really look for. So this is the individual who gets all the attention, and everyone kind of scratches their head if a person doesn't fit that category, but there's more than that individual. And then so, you want to be thinking about, well, at least in my line of work as a child psychiatrist, I'm thinking about the kid that's struggling at school. I'm thinking about, when I have mom and dad come in with the family or the child, I'm looking at mom and dad and I'm looking at their airways. I say, okay, wow, they have this, they have this nice cosmetic appealing, small, straight nose. But really, what does that represent functionally? Is it very difficult to breathe through? Or, do they have a receded draw and an overbite? Does dad look like he's getting tired in the interview? And then because this is telling me what are the genetics that are being inherited in terms of their airway. And so this is some data just kind of drive that point home. And so what they did was they did imaging of the airway of two different race cohorts, Europeans and the Chinese. And both of these individuals were representatives of their respective demographics. Okay. And so the European individual, both of them were about 65-year-old males, and both of them struggled with severe sleep apnea. So every hour they were failing to breathe, and they had an oxygen desaturation 60 times every hour. So every minute on average, you could say. And but what's interesting was the European was, as a 65-year-old male, was a stereotypical individual who was obese. The Chinese patient, on the other hand, was an individual who actually, by our current BMI standards, was considered basically normal weight, borderline overweight at 25.5. And so this is an important takeaway, is that as you're looking at the Asian individuals, which is a huge representation of our population here in Hawaii, it's important to understand that their anatomical airways are actually almost half the size of that of the Europeans. And so they have a completely different anatomy that predisposes them to them in some degree. So history taking, it's not about, do you have sleep apnea? What are the questions? It's about, what are the signs and symptoms of a face that doesn't breathe well? So as I'm going through a review of symptoms, I'm looking at, are you not refreshed upon waking? Folks will say, well, I even sleep 12 hours, but are you refreshed? A lot of times, the more they sleep, the less refreshed they actually are, because they're failing to breathe well. They oftentimes need to sleep in, and they're sleeping in for long periods. They're tired in class or when they're bored. And so just because a person's bored, it doesn't mean you should be falling asleep. And actually, if you look at a lot of kids, when they come into my office, they're exhausted and they're falling asleep, and it's like 4 o'clock in the afternoon. They say, well, it's been a whole school day. But if the kid goes to bed at 9 o'clock, you're telling me every day he's going through the day with the last 5 hours at least, where he's exhausted. And that's actually not common of the kids who are actually doing well. If you see a kid who's alert, awake, and they're breathing well, you actually will see the lights are on through most of the day. They're requiring a lot of napping. They have many awakenings. They're restless sleepers. The parents say, well, I put the kid down, so I know they must be a good sleeper at 9 p.m. And then they wake up at 6 a.m. and, they get their 9 to 10 hours of sleep. But oftentimes they're restless sleepers and they're not breathing well, and the parent's not aware of it because they've gone to bed themselves. The kid may be drooling because they're a mouth breather, so the mouth slit opens and then saliva pools out. So oftentimes they have to wake up in the middle of the night to pee, and that's because of a response by the heart secreting atrial natriuretic peptide, which causes the individual to urinate. Or the child may be a bedwetter. And oftentimes they may say they have a dry mouth, or they need water on their bedside table. They may have headaches or jaw aches. They may have nasal congestion or morning breath. And patients may report that, or families may report to the child that, at a younger age, they were sleepwalkers or sleep talkers. Maybe that may not be the case now, but what you're hearing is you're hearing the history of someone as you're putting these pieces together. It's not any one given piece, but you're hearing a history of someone who's having sleep problems, and what is the underlying cause that may be driving a lot of this. And so the psychiatric symptoms that they may present with are mood changes, anxiety, they're worriers, especially a lot of social anxiety is what we see, generalized anxiety. They're fatigued, they're feeling tired often. They're having difficulties paying attention, the kid showing up with the ADHD kid. Behavioral issues, they're acting out, their school avoidance and irritability. They may have treatment refractory psychiatric symptoms. They're of Asian ancestry. They have a family history for sleep disorders. So in my family history, what I found is more important. I check about things like with psychiatric histories, I check for things like, is there a family history for depression or cognitive disorders? But what I'm checking now is there also a family history for sleep disorders, sleep apnea, or, you're moving in your sleep, Or a lot of times families may say yes or no, they're not sure. And then I say, is there anyone that's snoring? And then they'll say, well, there's like half the family is the case that way. And now you're starting to see basically the predispositions actually occurring for the individual. I know there's adult and there's also child providers here. So in terms of adults, because a lot of times we want questionnaires, because of the reasons I've given you, and I actually don't use the stop bang, and I don't think it's very good at all because it doesn't represent our population. Because many of them, for instance, if you look at the questions in the bang question, they're not obese, you know, they could be younger, they're female, they don't necessarily have a large neck. And so you could actually have a lot of you could actually be missing a ton of cases by using this measure for looking for things. So oftentimes, if you use a stop bang, in my experience, you're finding someone with severe sleep apnea, and that's not the kid or even the young adult. So the question is, it's not about catching the severe cases. Those are certainly important, but how many times, how well trained are you to catch the mild cases in order to look for them? And that requires good history taking, and I would say examination. Pediatric sleep questionnaire, that is better compared to the adult one. Its sensitivity is only 78%. So keep in mind, in your clinic, that means if you use this exclusively, you will be missing 2 out of every 10 kids that would have tested positive, actually. And its specificity is 72%. So that's something meaningful, meaning that, you know, oftentimes in the cases who do get caught with this questionnaire, many of them, you know, do have some sort of sleep disordered breathing challenge. And so that shows you how prevalent it is when individuals are testing positive on many of these symptoms that they're presenting with. So the examination. So I'm not thinking about, is this a face of a sleep apnea? Is this a face that doesn't breathe well? Head and neck. So I'm not thinking about the waistline. I'm thinking about what is in the face that informs, the face is what informs me about the airway. You know, do they look sleepy? Or oftentimes they'll show up as looking very calm. And then, but if you look at them and as you talk to them, you'll realize that they're actually slow responders. And also, they're not necessarily alert. So usually someone who slept well is not just calm, but they're alert. And so they respond quickly, they process fast. You look around their eyes, they might have bags or shiners. And so that's that nasal congestion. And so you can see that their nasal passages are likely being occluded, maybe due to allergies or another reason. Mouth breathing, in fact, will actually cause a lot of nasal congestion. Their lips, don't ask them about it, or even while they're talking, when you're kind of taking your notes, just kind of observe them. And that's really when you're going to see the disposition of how that person breathes. As you look at their nose, you know, you can have them breathe through each nostril with closed lips. And then so you can get a sense of how well they're breathing through each nostril. And oftentimes, if you tell them to just keep breathing through one nostril, even for 10, 15 seconds, many individuals will say they get short of breath to kind of demonstrate how much of an issue for it is to breathe through their nose. Their cheeks. So you're going to see these individuals tend to have puffier jaw, puffier cheeks, and they tend to be more rounded. It's not like that square, solid jaw that Arnold Schwarzenegger has, but and really what it is it's enlargement of the muscles. It's hypertrophy of the muscles because they're working so frequently, oftentimes due to bruxism from clenching or grinding their teeth at night. If you look at the side profile of their face, oftentimes you may see a flat face or the smaller retracted jaw, and their teeth may be crooked, or maybe they've had dental appliances they told you out because they need to straighten out their teeth, and their bite may not be aligned. So when they bite down, oftentimes they have an overbite. If you catch a young kid, maybe the teeth are sticking out or the 2 front teeth are separated. And the teeth may show signs of wear from the grinding or clenching. And if you look at the tongue, you can see scalloping, and I'll show you pictures of some of these things. And the oral cavity, learning to kind of gauge that. So you can use something called the Malapati classification, which allows you to gauge how basically how enlarged that kind of airway is. And when you look for the tonsils, you want to see, are they past the pillars, the tonsillar pillars, or not? And is there hard palate? Always you want to look up into the hard palate and see, is it vaulted? Meaning, I'm going to show you a picture so you can understand that better. But this right here is a picture of someone who actually has a receding jaw. And so this is actually part of the issue. Is you'll see with their nose and also kind of with their cheeks and also with their lip, not just where that line is, their whole face is kind of dragged downwards. And you'll see they probably had some sort of cosmetic surgery, but actually if a person's tongue is in the correct position, it'll actually cause the jaw to grow forward, and it will actually cause the cheekbones to grow up, and the nose actually turns up. And so this is the effect of actually someone not having their tongue in the correct position for most of their life. And this is what mouth breathing does. So just looking at severe OSA, so you have an idea in terms of an imaging. If someone were to do a radiograph of someone who kind of has a retracted jaw on the airway, just comparing the left and the right, this is someone who's before and after a correction, I believe. You can see that by bringing forward the jaw, there's a massive increase in the airway diameter. And this is for someone who has severe sleep apnea. This is what bruxism looks like. If you look at this young lady on the left, basically it's a clinic that provides Botox to help people with bruxism because they want to relax the musculature, but it doesn't really get at the heart of the issue. And then maybe they might wear a dental guard to prevent things from grinding down. But what you see is if you actually relax the musculature, you can actually see how slimline the person's face is. And if we had a side profile, we could probably notice more features that are kind of showing up on them. And same thing for this gentleman, it looks like he has this hard square jaw, but in fact, if you actually plug some Botox into there, you can actually see the musculature shrink. It's not that his jawline is wide and well defined, it's that he actually has very strongly developed muscles of the TMJ region. And actually that's what's causing the expansion, and that's from constant grinding at night. And so just in terms of looking for grinding, what you typically may see is maybe features of worn teeth. You may see some recession around the gum line and what they call abrefaction. This is what scalloping looks like. So if you have a person kind of stick out their tongue, and you need to have them kind of stick it out right away after they keep their tongue in their mouth for a period, because the tongue will just kind of naturally return to its original position. But if they do, you can kind of see this indentation marks on the tongue. And that's because the tongue is pushing so hard against the teeth, because the bed for the tongue is not large enough. And so if it's having to push forward and there's no space, then basically the only option for that tongue to move is backwards. And so that's how you have a tongue that could be falling into the airway or getting pushed backwards. Malocclusions. So individuals who don't have a straight bite, oftentimes the reason they have a straight bite is because the jaw fails to grow forward. And when you have something like an overjet, or you have the front teeth sticking out, the reason that is because the tongue is basically pushing against the front teeth all night long, because it's trying to find space to breathe and open up the airway. And so the resulting effect is the kid actually has the front teeth stick out. And sometimes what we've seen, and what's commonly reported to the dentists we speak to, some of the airway dentists, is that after the kid gets kind of cosmetic dentistry and has braces to straighten things up, they start noticing that's when the behavioral challenge exists, or the difficulty sleeping sometimes gets a little worse. It coincides. And lo and behold, for a lot of kids, that's around ages 5, 6, or 7 grades 5, 6, or 7, or 8 for them. And so, oftentimes we may chalk it up to possibly other causes. And so this is the Malapati scoring classification. And so the short is just looking between class 1 and class 4 is you should basically be able to see down someone's airway. And so if it's partly occluded because the tongue is so high, or really the palate is just so high or so low, and it's not actually wide enough, then basically that is the airway someone is having to deal with as they're trying to breathe every night, and else that's occluding their breathing. This is just a quick picture of tonsils. A lot of folks are already aware of this, but what I just wanted to draw your attention to is as you're looking at the tonsils, before anterior and posterior, the tonsils are the tonsillar pillars. And so those pillars kind of define the boundary as to almost roughly, just roughly speaking, as to almost how far the tonsils may kind of come up to without necessarily having a significant impact on impinging the airway. But it may do so when the person closes their mouth. So, but just to give you an idea in terms of when you're looking at the tonsils and you're trying to gauge, well, is this a tonsil that sticks out far or not? If you look at the image on the right, you can see the tonsils are past the pillars, so much so that you can't even see the pillars behind the tonsil, or just barely. And this is the roof of the mouth. So on the left is the roof of someone's mouth who's actually, the jaw is correctly expanded. And you can see that it's pink, so there's good blood flow that's going to it, and it's wide. If you look on the right side, if you look at the teeth, they're straight in line. If you look on the right side, you see it's narrow, and it's so narrow, in fact, that you see these two blue streaks, and that's venous pooling. And oftentimes people, and that's what we call a vaulted roof, or what they call I think it's called a Gothic arch as well, in the palate. And the jaw actually grows very narrow. If you look at the teeth, they kind of come up crooked. So going on to the polysomnogram or the sleep study. So it's
I ask a couple questions first.
Sure.
You've got me looking at my tongue and measuring my mouth and everything. But one question is, how does the incidence of obstructive sleep apnea in children who have Down syndrome differ?
So the prevalence of sleep apnea in cohorts of Down syndrome, when they've looked at it, it ranges from 50 to 100%. So it's substantial. As to the specific cause, whether it's their tongue, that's certainly an impinging factor. But if you also notice, a lot of kids with Down syndrome have very small jaws as well. And then it could be exacerbated because now you have this mouth breathing kid. And so is he going to have a narrow or a wide upper jaw if he's not going to have correct tongue placement? So, and remember, the roof of the tongue, the roof of the mouth is the floor of the nose. So the higher that roof of the mouth goes, the more of the nasal cavity space you're losing.
And then another question is, does Chiari malformations push into the airway to cause obstruction as well? Or do Chiari malformations?
I have no clue.
Okay.
There's, but that's something worth for me looking to look into.
And then bruxism, about what percent, is there an estimate of how many people with bruxism actually have obstructive sleep apnea?
I haven't looked at the association of the statistic. I know it's a common co-occurring finding, and even a lot of the airways kind of go, even the guys that work on airways regularly go after that. But that's a good, both of those two are good questions for me to look into. This is helpful for me because it teaches me how to expand my questioning and research.
And last question for you. I've heard of a Korean device that pushes the teeth out to make more room in the jaw. I forgot the name of it. It's an appliance for both top and bottom. Do you know about that?
I don't specifically, but what I can say is there's probably tens of them out there. So that's the only reason why I don't know, is because there's so many. This is why one of my points for today is about learning to identify the professionals that work in that space, because this is more about, today's lecture is really learning how to be the quarterback on the management, not so much trying to get it all done yourself. And recognizing that there's a lot of specialties that are involved, and everyone is kind of like got one hand on the elephant in a dark room, and very few have actually the lights on, being able to see the whole thing. And that's really the point of the talk, is because oftentimes we get stuck in our silos, and then we are not necessarily aware of who are the other actually complementary specialties that could be helping me on this challenge. And then so that's part of my management as I go into it. I'm going to be expanding more on that. And then so with the sleep study, most people are aware there's the at-home, which is the top picture, and then there's the in-lab. Something to just be wary of. Convenience trumps everything when it comes to lifestyle and choosing what test you want. So most people are going to pick the at-home, which is virtually every adult. Kids cannot do the at-home, which is a good thing, because the at-home actually fails to report about 15% of cases. So if you have a patient that does an at-home, and you feel like they still do have like a lot of symptoms, but maybe it was missed on the test, strongly consider retesting in lab. So just to go down to the definitions, as per the American Academy of Sleep Medicine, defining a couple things. So the apnea hypopnea index, AHI, is basically defines how many times does an individual completely cease to breathe, or their breathing is slowed down to the point that they desaturate 3 to 4% oxygen per hour. Whereas the respiratory, so that is an index that was first created when sleep apnea was trying to be understood in its inception decades ago. Insurance companies have clung on to that, but they've still held on to it, despite the recommendation being to focus on the respiratory disturbance index now, because they're recognizing that that's actually a very low bar to set. And so most individuals who have AHIs below a 5 for an adult or 1 below a kid, is they're realizing that they do still have a breathing problem, but they can't get insurance coverage. And so what they're finding now is it's not just about looking at the apneas and hypopneas, but what are all the respiratory events that are going on that are causing an arousal for that person? And if you look at that, there's actually much more. And I'm going to show you an example of a sleep study for myself, in fact, just to give you a sense of it. And so I already mentioned this, what the cutoff was for adults of 5 and then 1 for children, as per insurance companies. Pulse oximetry reference value. So a lot of folks put a pulse oximeter on a person, or maybe look at the data and they say, oh, you're kind of breathing 97 or 98 or 96, you're kind of good. But what's the actual number? So I thought to include this chart, and you can look at it closer in your personal time with the slide deck I shared. But the take home is that whether it's a child from 1 all the way to the age of 50, well, for those individuals at 90 to almost 99%, I mean, the individuals only in the bottom 1 percentile always, and then for individuals who are adults, maybe all the way up to the bottom 10th percentile, will have an SpO2 or an oxygen saturation less than 98% at sea level, between 0 and 500 meters, which is about 1,500 feet. So that's something to keep in mind as you're measuring. When you check SpO2 and you see it's lower, take that into consideration. And so now you have a frame of reference in mind. So here we're looking at a sleep study for myself, and I highlighted the areas just to draw your attention quickly to. So my total sleep time was about just under 6 hours in this recording. And then what they look at is, if you look at the highlighted in pink, is there's my AHI, and it's referred to as PAHI because this was an at-home sleep study. And so they use a proxy is what they do. And over all night, it says 6.2. So I'm actually technically, most providers who look at that, I would get classified as mild sleep apnea, and I would just have, but just barely over the threshold. And even some providers said that to me. They said it's mild and it's not that bad. But if you actually look at how am I breathing through the REM, so during certain periods of the night, particularly during the periods where the brain is not focusing on recovering the body, but recovering the brain, I actually stop breathing almost 11 times every hour. And then when you actually look at the more clinically relevant number, not AHI, but RDI, which captures all of the times that I'm arousing in the night because I'm failing to breathe well, it's actually happening 15 times an hour on average. And in phases of REM sleep, it's happening almost every other minute, 27 times an hour. And so my mean saturation is 94 when I'm laying down at night. So I'm already desaturating. And then my minimum's dropping down to 82% at its lowest. This is kind of my data again. And what you're seeing is I'm just trying to, when you're looking at a sleep report, I'm just trying to give you some pointers in terms of as you're trying to make sense of all this sleep data. But learning to read the sleep data is really valuable because it actually puts the person's sleep in a perspective for you, rather than having to just depend on one sentence on the sleep report, which it's very rich in data. And this is actually really helpful at motivating patients to understand the scope of the problem at hand. So if you look, someone says it's an AHI of 6, okay, but here's what's going on. Throughout the night, you can see my pulse ox, my oxygen saturation, which is that black line, that wiggle in the middle, it keeps dropping. And if you look, whenever it drops, you're seeing my pulse rate, which is the red line, keeps spiking. So I don't actually sleep soundly through the night. My body is constantly secreting adrenaline, causing the body to react, and it's constantly awakening through the night. And that's what the top chart shows with the blue line. So you can see there's a correlation. And then you can see at the bottom line, or you can see in the bottom graph, there's that red line, and that's when I'm going into REM sleep. And this is what you actually see in a lot of individuals, is you'll see every time they start going into REM sleep, or they try to go into REM sleep, the body relaxes all of its musculature. And this includes the airway musculature. And then so you see these individuals, they start desaturating, their heart rate starts racing, and they have a respiratory event. And this just goes on and on and on through the night. And so the effect of that is a person actually has fractured sleep. So as a clinician, this is an important question, or as a provider, a healthcare provider, it's important to ask yourself what AHI should be shooting for. Is there a certain number that I should be shooting for at which the insurance companies reimburse at? Certainly it's a practical consideration, but clinically speaking, is good enough or mild? Is there such thing as a good enough severity such as mild? Are those the cases we say don't worry about it? And then, or should it be correlated with a clinical presentation that's coming in your room? So if a child or an adult is having difficulty with their mood, in my case, or they're having difficulty with behaviors, or they're having difficulty with their attention, and you're seeing that there's this case that's going on, it says it's mild sleep apnea, but they're constantly failing to breathe well through the night. And we know that if you don't sleep well, you're not going to be refreshed and necessarily do well during the daytime. Is that a clinically relevant finding? And so moving on to management. And so there's kind of two categories when it comes to management. There's compensating for breathing and there's correcting for breathing. And I'm going to go into that in more detail. So it starts off with basically a checklist, basically sending out a referral for a sleep study. And so this is a referral from one of the sleep centers, and I think they actually have one of the best templates, and it's something to use or just to remind yourself. I just wanted to show you this because most sleep centers will only put questions that are in the second or maybe in parts of the first column on their sleep form. But I just want you to know that this sleep center really understands the scope of things. So just looking through the first column, excessive daytime somnolence. Most kids are not going to, parents are going to say their kid's choking or they have observed apneas. They may have a small oropharyngeal opening when you evaluate things. They have a high Malapati grade. So it's basically another way of identifying a small oropharyngeal opening. Maybe they have enlarged tonsils or a large tongue if you have your Down syndrome patient. Going on to the third category, or the third column, you can see someone who has headaches in the morning, or maybe they're bruxing and they're having, maybe there's this is a different way of understanding maybe a relatively similar issue. You can have either headaches, or you may be aware that you're grinding your jaw. And then looking on to the fourth column, you'll see fragmented sleep. Are they waking up through the night? Are they not feeling like they've slept after a night? They're having a hard time falling asleep, or they're having a hard time maintaining their sleep. Or looking at the last category, depression, anxiety, ADHD, snoring, failure to grow. I don't see that necessarily a lot in my clinic, but at the same time, I really don't track for that. So maybe I should actually start collecting data so I really have a sense for it. But so these are all features, and the second column is kind of nice because some of our patients may have HMSA or HMAA if they have some sort of private insurer. And just looking on the far right, if the child is under the age of 18, they immediately classify for an in-lab sleep study. And there's your kid. But if it's an adult, someone with a mental illness, intellectual disability, they would qualify for the in-lab sleep study. So it's actually the better sleep study where we get more data. So you should be recommending that for your families if you really want the quality data. There's so these are the recommendations on my sleep report when it came back. So they said, you can do an in-lab sleep app titration. If not, you can do an auto CPAP, which is what I had. We can do positional therapy. So that's sleeping under a wedge, not two pillows. Two pillows doesn't really work because it doesn't properly elevate the body. And this can have a mild benefit. Some individuals notice there's an improvement. Then good sleep hygiene. I work with my families on regularity and duration of sleep. That could be a whole lecture, a separate lecture I could deliver. Because despite CBTI being helpful, there's no one who actually does it on the island, it seems like, or any of the islands. Efforts to optimize nasal airflow resistance. That's something I work with. And then there's a dental option so they can see ENT or a dentist for advancing the mandible. And so treatments. So the ones that are, I grouped them by what's covered and what's not, because that's an important thing. And so there's pharmacologic options, there's ear, nose, throat for the sinus and also upper airway or nasal cavity and upper airway. There's a weight loss program, or you can go with positive airway pressure devices like a CPAP. And the ones that are more variable coverage are, going to dentistry with the oral appliances or maxillary expansion. That can be very expensive, but it could also be definitive treatment we're talking about. And then same with oral myofunctional therapy. That in some cases can also be definitive treatment based on how early you get in with it, which is kind of like PT for the airway. So I'm going to focus today on the first four because a lot of providers, I understand, most likely in this forum are going to be working with people who use coverage. And in my case, with my families, a lot of them, they want to explore those as first options. And so that's where I always start. And that process itself of just going through those could be a process that may take 6 to 8 months as you're waiting for sleep study results and waiting for the ENT referral, and then you're considering alternative options.
We do
So
have a
something
participant whose husband had the maxillomandibular surgery in 2016 with complete relief.
Yeah, and that's actually a really common scenario to hear. So, when you guys, if you guys ever have the opportunity to start looking at airway dentistry, meet an airway dentist, and start looking at the results, you'll realize that those guys are actually the ones at the cutting edge of this whole thing. And they're the ones that really are advancing all of this. And I feel like they're addressing kids being tired, kids being lazy, or presenting as that, sleep problems. The kid who's just, if you see a kid who actually has their full airway included, it's like they turn into a rocket scientist. They just have so much energy and they start doing well in school and they start doing all their homework, and then they start going to after school activities. They want to play an instrument. They go right to bed and they knock out quickly. It's an unreal change. And so in terms of looking at the things that we can do, these are the things that are more affordable. These are kind of alternative means, things that we can use as a stopgap while we're waiting for our results to come in. We want to optimize the nasal breathing. Okay, so have them do a nasal rinse, wash it out. These are something to get from Longs. Some nasal spray, Flonase. Many families may be familiar with it, but they're not really using it. The ENTs want to see them using it twice a day, not 2 sprays once a day because it's convenient. Twice a day because it actually doesn't last for a full 24 hours when you put in the 1 spray, and so you get better results. And then to use something like a breathe right strip because it's a nasal dilator. So whenever you inhale, you're creating a vacuum, if you can think of it that way. And essentially what you're doing is you cause the nasal walls to collapse. And so what a breathe right strip does is it holds it open, and that can sometimes expand your nasal passage, just that portion of it at least, by 15 to 25%, depending on the person. And so it can be really helpful. And when you're sick, it's also a great time to wear it, because the reason a lot of people are so fatigued and exhausted, one major reason is you're not sleeping well because of that nasal congestion. And this is something that can help during those processes. And it also comes in kid sizes if you check on Amazon. This is just not to get into the depths of this, but just a quick tidbit, just kind of connect the dots, so to say. So looking at allergic rhinitis, you have your nasal congestion, and with that, you're going to get tonsillar and adenoidal enlargement, because those are immune tissues that respond to a foreign antigen coming in the body. And then what happens is you have constriction that occurs. And so you will actually have an individual where their airways, parts of the pulmonary tract, may actually constrict. And so it's not uncommon for them to experience features of airway constriction and hyperreactivity associated with asthma. And I actually just got off my last appointment before this presentation. I was talking to the family, I was talking to the mother of a child, and this kid has horrible allergies. And the mom is just adamant this kid has ADHD. But they moved into a home that had like mold and everything, and they cleaned it out, and it's been a substantial improvement. They're already seeing that. And the mom thought the kid had learning disabilities, and in fact they tested the kid, but they're 95th percentile for all of the subject areas. Really what they found out was the kid is just always tired, and the kid has low confidence. And that's another common one that parents are worried about. The kids, my kid has low confidence, what can I do? Let's bring him to a therapist. Actually, what we're seeing is if you address the airway and the person's breathing better, their confidence is going up. Maybe it's because they're feeling better. Just imagine yourself, on the days where you get to sleep in on the weekend, or when you go on vacation, you're feeling refreshed. You're feeling much more bright and energetic. But if you're someone who constantly has horrible, you mow the lawn, you feel like garbage, you're kind of withdrawn. And now think about a kid who has bad allergies, and this is just a day in, day out thing, a lifelong process for them. And the mom even said it herself. She said, I was on my way to contemplating whether this is just my kid. And that's the challenge I run into, because if I catch them by the time they're teenagers, the parents are adamant that that kid is just that way because they've always been that way. So they actually are just certain that this kid just needs a stimulant. And you can see them even falling asleep in front of you, and they're taking naps several times a day. And you can see they're just checking boxes in all these categories for breathing related challenges. And the family's like, yeah, but he's always been like that. Well, of course he has, because nothing has ever been done about it. And that is a process that can sometimes take those families months for them to come to understanding. And a sleep study can be very helpful for them. And as not only as a diagnostic, but as an educational tool.
And also facial injuries like bike accidents could cause this too.
Sure. Yeah. I mean, individuals, you have a deviated septum, or, you fall on your face and you have an injury. In my cohort of patients, it's not that common, but I would imagine that primary care providers probably see a way larger fraction of that. So they're the ones who are probably seeing those patients. And that's something that could be significant. The number of adults that have told me, like parents, that when I start talking about breathing, they're like, oh yeah, they just start talking about themselves and their deviated septum. It's such a common scenario. And I usually, I entertain it for a minute or two, and then I have to bring it back to the kid. But but the parents also become vigilant of what's going on. And as they start recognizing it with their body, they start seeing it, how it can be happening with their child. And oftentimes both end up start jumping on the bandwagon. But for ENT, a TNA, that's effective at resolving sleep apnea in about 50% of kids. So that goes to show, the tonsils and adenoids are not the only component that obstruct necessarily an airway in a child. There's multiple features. If the jaw is hanging down and we have this face that's drawn and hanging down, then it's not moved forward. That airway is constricted, as we saw in that radiograph of that individual. If an individual doesn't have good airway muscular tone, then basically the airway collapses every time the person inhales because it creates a vacuum. And so that's why airway specialists don't describe it as obstruction of the airway. They describe it as collapsibility of the airway. And so one of the concerns is they say, so some providers will say, well, 50% don't, 50% do, may benefit. Well, maybe we should do watchful waiting. That's a really dicey thing, in my opinion, because you really have to weigh the risks of a rapidly developing brain. Mind you, a 9-year-old, a 10-year-old, a 15-year-old, they develop in 3-month periods. You could say 3 to 6 month periods. They're not like a 50-year-old who's the same, maybe compared to when they're 52, versus a 9-year-old is a very different person by the time they're already 10 years old. And so the pace of neuronal development going on in that brain is much faster, and the trajectory is far more influenced. And so another procedure that ENT provides is a turbinectomy, or one of the ones that we commonly see, rather. And they perform these inferior turbinectomies. And with the ENT specialist, what I'm seeing is they don't necessarily remove the turbinectomy, but sometimes what they do is they kind of cause a fracture in the inferior turbinate, and they kind of push it out of the way. And then they have this procedure called coblation, which basically heats up the surface of the tissue, causing it to shrink a little. And that can open up the airway substantially. And they looked at a couple hundred kids who underwent that procedure, these young children, and they found out that nocturnal breathing was more regular, and it was improved in the 36 children who had a suspected history of sleep apnea. So not all the kids had sleep apnea in this study. They were just looking at kids in general who underwent that procedure. And they found that, almost all the kids with thick nasal secretions and failed antibiotic therapy had significant relief. So these are substantial procedures. And if you think about it, this is not just management. These are curative options. And so when you're thinking about a kid, a young person, even some older adults, do they want to adhere or use something that's going to go on for the rest of their life? Or do you really need to think about something, a solution for the short term, a solution for the medium term while we're waiting on everything to get lined up, and then a solution for the long term, something that's going to fix the problem for decades ahead? Weight loss is also an option. So actually, when we put on weight, it's not the weight on outside of our neck that collapses our airway. If we're severely obese, that could certainly be an effect. But actually, when you put on weight in actually the airway musculature and in the tongue itself. So if you look at an MRI of an obese individual, you'll actually see, and if they have genetics for it for adipose tissue to be distributed into their muscles, you'll see in the pharyngeal muscles, in the back of the soft palate, and also in the tongue, there's more fat in there. And what is that doing? That's basically enlarging those structures, and now they're impinging on that airway. And so they're seeing that if you have about a 10% drop in your BMI, so you take someone who's obese with a BMI of 30 and you want to bring them down to 27, you can have a 30% reduction in AHI. So it could be substantial. So a person who's about 5'9", the average male would have to lose about 20 pounds, and the average adult female would have to lose about 15 pounds. In terms of looking at devices, there's two devices here. You have CPAP and APAP, and the difference between them is APAP is an auto CPAP machine. So CPAP is a device where it pushes out a constant pressure of air every breath. So you usually have to go into a sleep lab where they figure out what is the right air pressure for you. And it tends to be more affordable, but it's not very accommodating if your breath changes, which it does with every breath, but also if you're sick, or let's say you had a procedure, there have been other changes. So you have to constantly get it reevaluated over its lifetime. APAP is much more flexible. That's why it's more expensive, because it's the savvier, the newer device. And what it does is it varies the pressure across a range that's defined by the physician, and it will actually vary with every single breath you take. And so if you're sick, or let's say, you just weren't breathing very well for one reason or another. Let's say it's super cold in your room, or it's super dry in your room, and your mouth is sitting open, then this will actually be able to accommodate to the pressure changes that occur as a result of that. So this is just a quick note for you, for individuals that, whenever they start talking about CPAP, they're like, well, how do I prescribe a CPAP? And they kind of get stuck into that. So I put a slide here that you can use. There's a slide deck that Summer has, and you can check in with her. And this is just a template prescription that I use. So you basically just fill it out and you can kind of send it off. And then so the most important thing is, if you decide to put someone on a CPAP or APAP, this is the most common APAP device out there. It's made by a company called ResMed, which kind of dominates the market now. And this is their most popular device, the AirSense 10. And but what's really important is adherence at 1 month is a predictor of adherence at 12 months. So it would be wrong for you to think that because you prescribed CPAP, the job is now done. Because 60% of individuals will go on, 40 to 60% of individuals will go on not being able to tolerate their CPAP machine. And most of them really won't tell you, actually. So what's absolutely crucial, if you decide to say, hey, go ahead and take this or consider getting this device, and you write that script, you make sure that you have them follow up with you within weeks after getting it, because it's absolutely crucial. They're going to talk to the sleep facility, the medical device manufacturer that provides it to them, or the retailer. But oftentimes that's not enough, is what I see. And the patients usually need several appointments. So understanding the most common problems can actually save you a lot of effort in the long run. So mask phobia is a common one, especially for your folks that are anxious. So have them wear it not at night for the first time, but wear it during the daytime while they're watching TV, so they can get desensitized from it. Maybe they have a sore throat when they use it because of air blowing down their airway. Have them turn up the humidity. If they bring in the device for you, it's very easy. Just like you see on the picture of this APAP, all you do is you go into the options, and then all you do is the humidity, you just tune that up. And then maybe the mask is uncomfortable, or there's a lot of air leakage, so they're going to need a different shape, or maybe they didn't choose the right size mask, and that's something that the vendor should be able to help them with. But the vendor, for instance, for me, the one they recommended ended up being wrong, and when I went home, I ended up finding out that there was a better fit for me because my mask came with different sizes. And so maybe they're mouth breathing, and so they're continuously having an air leak, so they're losing that pressure that's supposed to splint the airway open. And so there's something like mouth tape that they can use, or they could use a full face mask to help them with nasal breathing through the night. A lot of these devices have software attached to them, so it is absolutely crucial that you follow up every couple months and just have them bring in the software. It's usually an app on the phone, and just say, hey, let's look at it together, and you can see how much they're actually using it. So if they come back to you and they're saying, well, I still got these symptoms, and you're thinking, my gosh, are these treatment refractory symptoms, or did I not get down the issue? Oftentimes you will find compliance has dropped off. And so that is something that you have to be wary of, and you want to follow along. And so oftentimes therapists do a very good job at working with folks on their sleep hygiene and stuff. So if that person does have a therapist, consider getting them involved and say, hey, just so you know, we're working on their sleep, and this is a feature of it, and you can actually look at the data. And remember, the therapist is seeing the patient maybe every week or 2 weeks, and they're looking for solutions to help this individual as well. So they can actually be a team member in this process, and so can the family members. You want to empower them. Bring them both in, so that way they can understand what's going on. Explain the risk of no treatment. Sorry.
Sorry, it's our time is up,
Oh,
but
sorry.
Yeah. But we're going to have, well, Dr. Shipley come back. We'll have to have
Mhm.
you come back too, because this really is fascinating, as one of the commenters said. Okay, we're pretty close there. And it sounds like, oh yes, will someone who has been using CPAP for years find APAP easier to use?
That's a good question. I actually don't know that because I tend to work with young people, so I don't have a large cohort of individuals having to switch. Um, but if you have troubles with CPAP related to pressure, then you know, in terms of maybe when your state of your health changes or just over time, you have to go into the lab or something, you may find those types of issues to be better addressed by the advantages of using an APAP is what I would think.
Okay, well, thank you so much. And we are going to reschedule you. And I have a perfect patient for you, that, because usually we have case presentations too. And, you know, we don't really have sleep apnea case presentations. So I have the perfect case presentation for future times.